Assalamu alaikum. Now there's the time to finalize our session with thyroid disorder. That's a part 3 that carry all clinical background related to thyroiditis. And with thyroiditis, that's an inflammatory problem. Sometimes due to some underlying etiology, here there's a type of thyroiditis. Types may be infectious, likely acute thyroiditis, suburative thyroiditis, and some subacute, like granulomatous thyroiditis, either painful or Quervain thyroiditis. Some type of thyroiditis, like autoimmune thyroid disorder or autoimmune thyroiditis. The most common two main autoimmune thyroid disorder, the Hashimoto thyroiditis or Painless postpartum thyroiditis. Another types, Painless sporadic thyroiditis, drug-induced thyroiditis, Riedel Thyrioditis, and others like trauma and radiation. So, what about acute thyroiditis like any abscess? Rare, usually bacterial, and treated like any swelling with underlying inflammatory problem and was incision and drainage with anti-inflammatory antibiotics and pain relief, and the patient will recurrent and return back to be in normal condition. Subacute thyroiditis, Quervain thyroiditis. Sometimes viral in nature. Histologically, the inflammation is granulomatous. Patient have painful, tender thyroid gland and may have systemic symptoms like fatigue, bone ache, malaise, fever, nausea, vomiting with increased erythrocyte sedimentation rate. And that's thyroiditis temporary. What's meant by temporary? Here start by activity of the gland, start by the thyrotoxic state with the high T3, T4 and suppressed TSH. With very few weeks, with exhaustion of the gland, the patient returned back to normal. So the second stage is euthyroid state with normal T3, T4, TSH. With more exhaustion of the gland, the problem turned to hypothyroid stage with decreased T3, T4 and high TSH. And this condition here, the patient present with clinical symptom with hypothyroidism. After very few months, there is a recovery. So you should understand sometimes we have a change in the presentation of the gland with early stage of the subacute thyroiditis. The patient come to us with a toxic state, toxic symptoms and signs with anxiety, tremors, weight loss. Very few weeks, the patient return back biochemically and clinically to normal. After that, hypothyroid. So you should have multiple tools to make accurate judgment and accurate diagnosis of your patient, just that help you to select appropriate management plan. Hashimoto thyroiditis, that's the most common type of thyroiditis. That's characterized by the presence of the high serum anti-thyroid antibody, thyroid antibody, anti-thyroglobulin antibody, and the anti-thyroid peroxidase. By examination of the gland are firm, rubbery, symmetric, painless goiter is frequently the initial finding. So your patient with Hashimoto thyroiditis, diffuse goiter, enlarged like Graves in the first stage. That's Hashimoto, and that's dense lymphocytic infiltrative, mean that's inflammatory with underlying autoimmunity. Here, in this patient, 90% of cases have anti-thyroid antibody, TPO, thyroid peroxidase antibody, and some 20 to 50% of patients have a thyroglobulin antibody. Once overt hypothyroidism is present, levothyroxine treatment of choice. Here, this patient with the just Hashimoto thyroiditis carry same career of subacute thyroiditis. Like patient with this problem with the high TPO antibody and thyroglobulin antibody with the high T3, T4, low TSH with diffuse gland, that's called the autoimmune thyroiditis Hashimoto, start by thyrotoxic state. Very few weeks. After that, the gland exhausted, returned back to euthyroid state. Then after that, hypothyroid. And so if you have patient practically come to you with diffuse thyroid gland with high T3 T4 TSH, T3 T4 and suppressed TSH with all manifestation, so here you start to think. After asking for hormone, you should ask for antibody. In this patient have TSH receptor antibody, that's Graves. At this patient, you should complete clinically the syndrome of the eye and the skin, and more and your treatment plan here differ. You should start by the immunosuppression and then antithyroid treatment. But if your patient have diffuse enlargement of thyroid with very high TPO antibody with antithyroglobulin antibody and no other manifestation all over the body, now your patient have thyrotoxicosis with underlying autoimmune thyroid disease like Hashimoto thyroiditis. Why we can do this accurate diagnosis? At the patient of Graves, you should start antithyroid and immunosuppression. In a patient with Hashimoto thyroiditis, no need for antithyroid at all. And you should start by the propranolol or Indral only to alleviate symptom till the second or third stage become to be appeared and the patient have a self-limited changes from thyrotoxic till euthyroid till hypothyroid. So in a patient with thyrotoxicosis, be cautious with judgment. You should have all over the time have a definite diagnosis rather than symptomatic or rush for antithyroid. Please again, you should diagnose your patient well. Painless postpartum thyroiditis is associated with pregnancy and lactation. Painless postpartum thyroiditis causes lymphocytic infiltration of the thyroid within the first few months after delivery, and the disease characterized by no thyroid pain, just mild enlargement with a normal erythrocyte sedimentation rate (ECR) and a high serum thyroid peroxidase concentration. In most patients coming to us with the painless postpartum thyroiditis, a small non-tender firm goiter is present, classic symptom of triphasic thyroid hormone pattern. Don't forget, triphasic thyroid hormone pattern. Again, triphasic thyroid hormone pattern that include thyrotoxicosis, typically begin 1 to 6 months after delivery and last for 1 to 2 months. And the second phase that may followed by hypothyroid phase, starting 4 to 8 months after delivery and lasting for 6 months. 8% of women recover to normal thyroid within years. Permanent hypothyroidism develop within the severe hypothyroid patient with 20% of patient and a similar number in the persistent mild abnormality here, this painless postpartum thyroiditis. So any change like depression, fatigue, constipation, weight gain after delivery, think thyroid, please. Think thyroid and ask for TSH and anti-thyroglobulin antibody and antithyroid peroxidase. Lymphocytic painless thyroiditis. Some investigations believe it is a variant of subacute thyroiditis. Others believe it's a variant of Hashimoto thyroiditis, and also the condition go with the triple thyroid response: hyperthyroidism, euthyroid, then hypothyroidism, followed again by a return to the euthyroid state. Each phase usually lasts for 2 to 3 months. Can only be diagnosed by the radioactive iodine test. Here in this patient, if you have a radioactive iodine, so there is no uptake at all, and the very minimal uptake due to infiltration by the lymphocytes. Treatment is based on symptoms. Again, beta blocker relieve rapid heart rate and excessive sweating during the hyperthyroid phase. Riedel Thyrioditis, and it's a rare condition. This chronic inflammatory disease of thyroid gland characterized by dense fibrosis, sometimes woody gland, woody like very hard and not firm, very hard, that replace normal thyroid parenchyma. And the fibrotic process invade adjacent structures of the neck and extend beyond the thyroid capsule. Here, thyroid function depends on the extent to which the normal thyroid gland has been replaced by fibrotic tissue. Most patients are euthyroid but hypothyroid is noted in approximately 30% of the patient. And lastly, that is the diagram and in the form of table that give you a chance to make full detailed characteristic and differentiation between Hashimoto thyroiditis, painless postpartum thyroiditis, painless sporadic thyroiditis, painful subacute thyroiditis, suppurative thyroiditis, and Riedel Thyrioditis. Finally, with the finalizing your session with me with thyroid disorders, please, when you start judgment a case of thyroid disease coming to you, sometimes coming to your clinic as a goiter, and your approach to a case of goiter. And in a case of goiter here, your patient sometimes have simple goiter. Simple goiter likely to be in the physiological one, like pregnancy, like puberty, and some area lack of iodine. The second one, other than thyroid enlargement, likely to be physiologic, and this patient with physiological goiter or physiological enlargement of this goiter need no intervention. So there's the first one can help you to be diagnosed as a one approach. Second type of patient sometimes coming with goiter with toxic manifestation like tremors, weight loss, irrespective of the very good appetite, insomnia, anxiety, fatigue, menstrual disturbances, diarrhea, and so on. So in this patient, stay with patient very few minutes to take a history. If there is a manifestation of thyroiditis or a manifestation of Graves, and then ask patient to be ready to be examined. If the patient have a diffuse goiter, here you have two ways. Diffuse goiter with toxic presentation, here you should ask for thyroid autoantibodies. TSH receptor antibodies, here your patient now become Graves, so search for eye and other systemic symptoms. If your patient have symptoms vague and presence of the autoantibodies, antithyroglobulin antibody, antithyroid peroxidase, your patient now thyroiditis. Why we can do this, and we need to make this accurate diagnosis? Because of patient with Graves, start to project medical treatment, radioactive iodine, and ask for thyroid scan. In a patient with Graves, there is a very high uptake with the scanning. In a patient with autoimmune thyroiditis, no uptake at all. Why we need to differentiate again? Because patients with Graves have to be treated well with antithyroid treatment, and if a patient have exophthalmos and thyroid eye disease with the no specs give severe activity, you start here corticosteroid treatment. But if a patient would have thyrotoxic diffuse goiter with the thyroglobulin antibody and thyroid peroxidase, no need for antithyroid treatment. Just give propranolol only. You should differentiate here. Another types of patient with the nodular goiter with toxic manifestation with more T3, T4, and little TSH. So your patient now called toxic multinodular goiter or single nodule toxic nodular goiter, solitary thyroid nodule. You should treatment, tell patient control, then ask for surgery or radioactive iodine. Another types of patient come with goiter to your clinic. Here your patient come with the just goiter, just adenoma, no symptoms and signs. Just take a biopsy, ask for hormone, and try to judge if needs thyroidectomy or not. Another type of patient come to you with mass plus hoarseness of voice plus pressure symptoms, sometimes weight loss. Let's give you a chance to understand that your patient have underlying malignancy, papillary thyroid cancer, anaplastic thyroid cancer, medullary thyroid cancer, or follicular thyroid cancer, and sometimes lymphoma. 5 types of thyroid malignancies. So in this patient, you should have suspicion of the patient. Mass, sometimes firm to heart with pressure symptom, sometimes retrosternal extension, again hoarseness of voice, weight loss, anorexia, nausea, sometimes with normal thyroid function. Here, you should have judgment of general systemic condition and local signs. You should ask for fine needle aspiration cytology and radiothyroid scan. Fine needle can give you a chance to understand the tissue with pathological background and scanning. That's another approach to goiter. Last one is thyroiditis with different symptoms and signs. Don't forget with a patient with thyroiditis that your patient have triple phases. Triple thyroid phases. Start toxic, very few weeks. Then euthyroid state, then hypothyroid state. According to a presentation of the patient at this time, you can make judgment. Please don't treat hormone itself. With thyroid disorders, no need for rushing to treatment thyrotoxic patient until you should know the underlying background. With thyroid, either physiological changes or toxic changes or just adenoma or sometimes malignancy or sometimes autoimmune thyroiditis or other inflammatory condition like Riedel and Quervain Thyroiditis. And the final stage of my presentation, again and again, you should have accurate judgment and accurate diagnosis of your patient. Thank you very much.